Is to speak to you about interventions, not only transcatheter interventions, but also surgical interventions for valvular heart disease in 2020 and beyond. It's a great pleasure to speak after Steve from the Mayo Clinic and to contribute to this very important joint symposium. The field of intervention for valvular heart disease is moving at an incredible pace. And what I hope to do in the next half an hour or so is illustrate to you how the evidence base is evolving very rapidly and how we accommodate this evidence into everyday clinical practice, tinged for this audience with the realities of working in the NHS. And I want to look back, first of all, not very long ago, but to 2017, when the European guidelines were last updated, and Steve very kindly attributed several of his slides to these guidelines, which were indeed very helpful in clarifying the field and putting forward the specific advantages of joint heart team working between interventional cardiologists, diagnostic cardiologists, or imagers most classically, and also our surgical colleagues. And it is interesting to look back only 3 years to realise that at that time, surgical aortic valve replacement was deemed the gold standard for the majority of patients with aortic stenosis, those who are of younger age and lower risk. And really, TAVI in 2017 was still an exclusion intervention for those who weren't considered suitable for surgery. This slide demonstrates the even evolution of practice in the UK over the last 10 years or so since the arrival of TAVI in the late part of the first decade of the century. And you can see here that there has been a rapid rise in the scale of activity of TAVI, which in 2016 approached surgical numbers, and I can tell you has now surpassed that number in the most recent BSIS audit. Part of the reason for that was that the interventional cardiologists got very good at TAVI very quickly, and mortality and significant complications of the intervention fell dramatically due to a very rapid learning curve and advances in technology, making the procedure simpler for even the most humble interventional cardiologist. And indeed in Germany, where of course they have a very different healthcare financial model, you can see here that even more recent data show that the number of TAVI procedures, here illustrated in green, now far outpasses the combined total of aortic valve surgery for all comers, whether or not it includes concomitant coronary artery bypass surgery. And these trends are now being observed in the US, I think I'm right in saying, Steve, and in France and Switzerland, and it will be no surprise, of course, when they eventually arrive on these shores. So in 2020, we can say that TAVI is a procedure which in the best centres has a 1% inpatient mortality, your magic number, Steve, 1%. It has a small risk of complications, particularly stroke and vascular episodes. It is a procedure that can be performed in 1 hour. It can be performed under conscious sedation or local anaesthesia, and the patient is usually in hospital for 2 days or less. It is therefore no surprise in the UK, and I appreciate this isn't a US problem, Steve, that we now face the problem of a rapidly accumulating waiting list. So what's brought about this transformation of practice? Well, this is a summary slide outlining the evidence base which has supported the growth of TAVI for aortic stenosis over the last 10 years. The seminal partner trials, their companion trials evaluating self-expanding valve technology, and the evolution of guidelines on both sides of the Atlantic over time to indicate the support for TAVI, initially in inoperable patients, latterly in high risk, certainly now in intermediate, and potentially in low risk patients too. And here we are 1 year ago at the ACC, where the simultaneous presentation and publication of the low-risk trials evaluating the balloon expandable S3 valve and the evolute self-expanding valve in randomized fashion versus surgery demonstrated very, very favorable results in support of a transcatheter technology, with reduction in the composite endpoints illustrated here in both trials. Now, if you put these trials together with the pre-existing evidence from the high-risk, inoperable and intermediate-risk patients, you can perform meta-analysis, which is a burgeoning sport in the 21st century. But this is one of many meta-analyses which were published in the wake of these trials. And you can see that the balance of probability favors TAVI just. But recall that TAVI technology evolved very rapidly over time, and recall in particular that transfemoral TAVI is now applicable in 95% of patients, and the analysis is very strongly in favour of TAVI if it is feasible via transfemoral approach. So the first paradigm shift I want to convey to you is that if we have evidence across the spectrum of risk, then the former model for selection of these patients is no longer applicable and becomes independent of the risk score assessment of surgical outcome. In other words, it's a no-brainer that transcatheter technology is going to become the dominant interventional modality. There are, of course, many, many remaining challenges, and I don't have time to present all of these in detail, but I will focus on the most important, and that is currently durability, because we recognise that we do not have long-term data for TAVI extending beyond 5 years in realistic terms currently to match the very long experience in surgical aortic valve replacement. But I would remind you that cardiac surgeons for the last decade have been using bioprostheses in younger and younger patients, even patients in their 50s, often without data concerning the valves that they are implanting, and in the certainty that they will require a second intervention at the age of 70. So when we have dialogue with our surgeons, and on the whole it's a constructive dialogue, we need to recognise that the surgeons need to play the game consistent with the rules. Because we do have quite strong data for TAVI at 5 years now from the original randomized trials with the earliest TAVI iterations, and if anything, they are suggesting that TAVI valves may be more durable than surgical bioprosthetic counterparts. Now, the proof of the pudding will be in the next 5 years when we go out to 7 years, 10 years, and perhaps beyond. And we need to be cautious in our enthusiasm for transcatheter technology, and we need to be very open with our patients about the uncertainties regarding durability. And I'm certainly not here to make a call that everybody should have a TAVI. But I think we do need to recognise in the 21st century that patients have some say in their treatment, and it's our responsibility to guide patients in these often very difficult decisions. We also need to remember that the coronary arteries are frighteningly close to the aortic annulus. And if we're going to start putting TAVI devices in young patients, then these patients may well develop incident coronary artery disease over time, and some of them may present to a primary angioplasty centre which has no experience of performing TAVI procedures. So access to the coronary arteries is often difficult, and certainly doing PCI through the struts of a crowded aortic route with struts of a TAVI device can be a very challenging undertaking. So we need to recognise a new set of problems that we are creating. We also need to recognise that we are not yet in a position to deliver the tsunami of demand for TAVI, certainly in the UK. We're now doing 5,000 TAVIs per year in the UK, and we are saturated. We don't have enough cath labs, we don't have enough operators, and we don't have enough widespread expertise to offer TAVI to everybody who needs one according to guideline indications. And we need to think about that very seriously as a community. Because I want to point out on this slide again that the growth in TAVI here was not achieved at the expense of a fall in SAVA numbers. In other words, we were dealing with the unmet needs of elderly, frail patients who weren't suitable for surgery. And the difficult days for the heart team are coming here, where we're going to start intruding in each other's territory. Because the paradigm shift 2 that I want to convey to you is that rather than TAVI being applied to patients who are not suitable for SAVA, it may well be that TAVI will now be the default treatment and surgery will be reserved for those patients who are unsuitable for a transcatheter approach. Think about it. Because we recognise over time that practice evolves, whether it's in hepatobiliary surgery, whether it's in obstetrics and gynecology, whereby surgery sets out as the only treatment, but over time, transcatheter technologies become as good as and eventually supplant the traditional mode of treatment. So for the time being, we have many, many challenges. TAVI go, go, go is the algorithm, and there will be a lot of work to do. And at this stage, it's conventional to show a slide something like this, which is surgeons queuing up at the dole queue. But some of my best friends are surgeons, and I want to make the case that we will always need them, we will always love them, and there are plenty of patients left for them to treat because, for example, here are the inclusion criteria for the low-risk trials. And you can see here that there were no patients with bicuspid valves, there were no patients with multiple valve disease, there were no patients with severe coronary disease, and there were no patients with hostile TAVI anatomy. So if we're going to be an evidence-based discipline, then we need to accept that we do not yet have evidence to apply TAVI, certainly in these subgroups. We also need to recognise that valve disease is a lifetime journey, and you only want one median stenotomy in your life. And we need to work out what the new algorithms of treatment are going to be for patients with aortic stenosis in their 40s or their 50s. Because it may well be, let me challenge you, that TAVI is the right first treatment, followed by surgery in your 70s, and a valve-in-valve TAVI, operation number 3, in your 80s. There are lots of new options, and there are lots of new ways in which we need to think. Let's switch gear. Aortic regurgitation, Steve will be talking about later on. We also need to comfort our surgeons that we don't yet have good TAVI devices for aortic regurgitation. Very often these patients have large aortic annular dimensions, and they very often have associated aneurysmal disease of the aortic root. And surgery is the only feasible treatment. We also need to recognise that the aortic valve is a very, very simple valve. 3 leaflets in a tube. It's like putting a stent in the mid-right coronary artery. The mitral valve, in contrast, is an extraordinarily complex anatomical structure. Its physiology is even more complex given its interactions with the subvalve apparatus and the left ventricular myocardium. And as we shall see, interventional cardiologists are struggling to find tools that are useful in this anatomical position. Steve mentioned mitral stenosis, so I'll touch on it very, very briefly. Well, we have had a transcatheter technique available for many, many decades now, balloon mitral valvuloplasty, and that is a very, very good treatment for patients who are anatomically suitable, indicated here. But we do need to remember that rheumatic disease is also very rare in the UK, probably more frequent than in the US, but nevertheless very rare. And even the most experienced interventional cardiologists are only doing maybe 5 balloon mitral valvuloplasties a year. It's very different from India or sub-Saharan Africa, where these procedures are done on a weekly basis, almost daily in some institutions. So we need to recognize our limitations, and we need to remember that many patients who are elderly with mitral stenosis are not suitable for a balloon approach. We also need to remember that the surgeons have exquisite skills in repairing the mitral valve, and for many years surgical valve repair has been the gold standard treatment for this particular disease, with numerous advantages illustrated on this slide. And for that reason, the European guidelines and their counterpart in the US have strongly recommended mitral valve repair, regardless of the presence or absence of symptoms based upon very nice natural history data, and have recommended a very low threshold for surgical intervention when repair is feasible in expert hands in a high volume centre. I'll say that again, in expert hands in a high volume centre. I'll turn now, because I'm here really to address the transcatheter brief, I believe, as much as the surgical brief, to the field of secondary mitral regurgitation, a much more complex disease, illustrated here, where the primary pathology resides in the left ventricular myocardium, and mitral regurgitation is a secondary phenomenon, secondary to annular dilatation. And you all know, and we all know, and the guidelines acknowledge that medical therapy for heart failure has a huge evidence base in many tens of thousands of patients, demonstrating dramatic reduction in mortality, need for hospitalization, and symptomatic status. And we need to emphasize that medical therapy remains the mainstay of management of left ventricular myocardial disease with or without mitral regurgitation. And by that I don't mean Ramipril 1.25 milligrams and discharge to the GP. I mean full so-called guideline-directed medical therapy to the maximum that will be tolerated by the patient. And that requires the support and the coordination that's provided by heart failure specialists and their services. We have reasonable evidence from the CARE-HF trial in particular that cardiac resynchronization is of value in patients with left ventricular failure as a consequence of myocardial disease. And there are some subset analyses suggesting that it may well also be of benefit in patients who have associated significant mitral regurgitation. So the second stage of the algorithm is to consider CRT in those patients who satisfy criteria for that particular intervention. In contrast, the role of surgery has been very limited to date. And despite lots of enthusiasm and the skills of surgeons reconstructing the mitral valve in patients with heart failure, the evidence supporting this practice is very limited, and in reality, it's very rare for patients to go to the OR for surgery for this indication alone. And that is a global statement. So the stage has been set, therefore, for some while for consideration of transcatheter options, illustrated here, the edge-to-edge repair procedure using the MitraClip. And it's worth pointing out that this technique has now been available in commercial practice for 15 years. That may surprise some of you, given that the furore has only really risen in the last year. And a similar evidence time chart here demonstrates the paucity of evidence over time. The Everest 2 is the only randomized controlled trial historically which looked at both primary and secondary mitral regurgitation and had rather weak endpoints supporting its positivity. There was then an emergence of registry data, particularly from Central Europe, and it was only in 2018 that we arrived at the point of robust randomized controlled trials, illustrated here. And you will well know, because it's been covered very extensively in the literature, that these trials produced divergent results. The Mitra France study, which was perhaps based on everyday clinical practice, with randomization during the optimization of medical therapy, demonstrated equivalence between mitral edge-to-edge repair or medical therapy. Whereas the COAPT trial, which took a more robust approach to guideline-directed medical therapy and its introduction, was overwhelmingly positive, not only for the primary endpoint of hospitalization for heart failure, but also across a variety of secondary endpoints, including mortality. And this is difficult, and in fact 21 editorials have been published across the world's literature trying to make sense of these divergent results. And I've summarized it in 3 points here. The first is that you have a lot of MR but not a bad ventricle, then it makes sense to fix the mitral valve, and that would support the COAPT philosophy and the subsequent discussion regarding proportionate or disproportionate mitral regurgitation. Secondly, you should only offer an edge-to-edge repair procedure if your patient is already established on guideline-directed medical therapy and still symptomatic. And thirdly, if you're going to do a MitraClip procedure, then do it well, use multiple clips, and make sure that there is very little mitral regurgitation at the end of the procedure. Because practice in the Mitra France trial was adoptive and within the learning curve of most practitioners, many of whom implanted only 1 clip in their patients, and many of whose patients were left with significant residual MR at the end of the procedure. So we have more questions than answers in terms of mitral valve intervention for secondary mitral regurgitation, which relate to the complex pathophysiology of the disease and the fact that we still need further evidence to guide our practice to work out which patients should be the beneficiaries of this useful but still expensive technology. And we need to remember also that there are many other devices emerging down the track, not only in relation to alternative modes of edge-to-edge repair, but also indirect and direct annuloplasty, techniques for transcatheter caudal repair, usually in the hands of surgeons, and also potentially the holy grail of transcatheter mitral valve replacement. And we've tried to encapsulate all of these difficult discussions in a 4-association set of recommendations which are currently under review by the European Heart Journal, and I hope will be published later this year. So in conclusion for this first talk, I want to summarize by saying, consistent with Steve's presentation, that valve disease is an emerging epidemic and it has major healthcare implications. TAVI is now arguably the gold standard in aortic stenosis, but we need to remember that there is plenty of work left for the cardiac surgeons. We have ongoing trials in younger patients and those who are asymptomatic with aortic stenosis to tell us how to manage them. We have ongoing trials in the field of mitral regurgitation and heart failure, which will tell us how to manage these difficult patients in the future. And by working together in valve centres of excellence as heart teams, we will hopefully secure a better future for our patients. Thank you very much.
So please save your questions for the panel Q&A, which is at the end of this morning. And if you could please